Ovarian cysts are an extremely common occurrence in women throughout their reproductive years. Hearing the word cyst can immediately cause concern, but it is vital to understand that the vast majority of ovarian cysts are harmless, non-cancerous, and are a normal, functional part of the monthly menstrual cycle. They are simply fluid-filled sacs that develop on or inside an ovary. Most of the time, these cysts cause no symptoms and resolve on their own without any need for medical intervention. Understanding the nature of ovarian cysts, why they form, and how they are managed is a key part of understanding your own body and reproductive health. This knowledge empowers you to navigate any diagnosis with confidence and perspective, separating common physiological events from the rare but important concerns that require medical attention. The different types of ovarian cysts are generally categorized into two main groups: functional cysts, which are directly related to the process of ovulation and are the most common type, and pathological cysts, which are less common and develop for other reasons. Functional cysts. These cysts are a sign that your ovaries are working as they should be. They are almost always benign and are a direct result of the hormonal processes of your menstrual cycle. Follicular cysts. Each month, in response to hormones, your ovaries grow several small sacs called follicles. Inside each follicle, an egg develops. Around the midpoint of your menstrual cycle, a surge of luteinizing hormone, or LH, is supposed to trigger the dominant follicle to rupture and release its mature egg in the process of ovulation. A follicular cyst forms when this hormonal signal is not perfectly executed and the follicle fails to rupture. Instead of releasing the egg, it continues to grow, filling with more fluid. These cysts are typically painless, rarely grow larger than a couple of inches, and almost always disappear on their own within 1 to 3 menstrual cycles. Corpus luteum cysts. After the follicle successfully releases its egg, the ruptured sac transforms into a small, temporary gland called the corpus luteum. The corpus luteum is essential as it produces hormones, mainly progesterone, to prepare the uterine lining for a potential pregnancy. A corpus luteum cyst forms when the opening of this sac seals off, trapping fluid inside and causing it to grow. These cysts can sometimes cause mild discomfort or a feeling of fullness. If you become pregnant, the pregnancy hormone HCG keeps the corpus luteum active and producing progesterone, which can sometimes cause it to become larger and persist into the first trimester before eventually resolving. Pathological cysts. These cysts are not related to the normal function of the menstrual cycle. They are abnormal growths that can form on the ovaries. While most are benign, they carry a slightly higher risk of complications and are therefore monitored more closely. Dermoid cysts, or teratomas. These are unusual cysts that form from embryonic cells, which are the primary cells that can develop into any type of body tissue. Because of this, dermoid cysts can contain various types of mature tissue, such as hair, skin, fat, bone, and even teeth. While this may sound strange, they are fascinating from a biological standpoint and are almost never cancerous in women of reproductive age. However, they can grow large and may need to be surgically removed to prevent complications like ovarian torsion. Cystadenomas. These cysts develop from the epithelial cells on the outer surface of the ovary. They are typically filled with a thin, watery fluid called a serous cystadenoma, or a thicker, mucus-like fluid called a mucinous cystadenoma. They can grow to be quite large, sometimes several inches in diameter, but are typically benign. The endometriomas. These cysts are also known as chocolates. This name comes from their contents. They are filled with old, dark, thick menstrual blood and tissue that looks like melted chocolate. They form in women who have endometriosis, a condition where the tissue that normally lines the uterus, the endometrium, grows outside of the uterus. When this tissue implants on an ovary, it continues to behave as it would in the uterus. It thickens, breaks down, and bleeds with each menstrual cycle. With no way to exit the body, this blood and tissue becomes trapped, forming a cyst that can cause chronic pain and inflammation, potentially damaging healthy ovarian tissue and impacting fertility. Causes and risk factors for ovarian cysts. Functional cysts are caused entirely by the complex hormonal fluctuations and physical events of the normal menstrual cycle. They are a byproduct of ovulation and are not preventable. Pathological cysts have different origins. Dermoid cysts are congenital meaning they have likely been present in a dormant state since birth. Cystadenomas arise from the ovary's surface cells for reasons that are not fully understood. Endometriomas are a direct manifestation of the disease endometriosis. Certain factors can increase your likelihood of developing cysts. These include hormonal issues. Taking clomiphene, a fertility drug that stimulates ovulation, can increase the risk of developing corpus luteum cyst. Pregnancy, as noted, a corpus luteum cyst is a normal and essential part of early pregnancy. Endometriosis, this condition is the direct cause of endometrioma. A severe pelvic infection, infections that are severe and untreated, can sometimes spread to the ovaries and fallopian tubes, leading to the formation of abscesses or inflammatory cysts. It is also important to clarify the term polycystic ovary syndrome, or PCOS. Despite the name, PCOS is not a condition defined by having large, problematic cysts. It is a complex metabolic and endocrine disorder characterized by hormonal imbalances that interfere with or prevent regular ovulation. This disruption can lead to the appearance of many small, undeveloped follicles on the ovaries, which are visible on an ultrasound. These are not true cysts in the same way as the others described. They are follicles that have been arrested in their development. The clinical course and symptoms of ovarian cysts. The clinical journey of most ovarian cysts is silent. They form and resolve without a woman ever knowing they were there. When symptoms do occur, they are often vague and can be mistaken for other conditions, such as irritable bowel syndrome or menstrual cramps. Common symptoms can include pelvic pain. This is the most frequent symptom. It can be a dull, constant ache or a sharp, intermittent pain localized to one side of the lower abdomen. Bloating, fullness, or pressure. You might feel a persistent sense of heaviness or pressure in your abdomen. Pain during intercourse, especially deep pain, known as dyspareunia. Painful menstrual periods. Cysts can sometimes worsen existing period pain. Changes in urination or bowel movements. A large cyst can press on the bladder or bowel, causing a frequent need to urinate or difficulty with bowel movement. In some cases, a cyst can lead to more severe complications with distinct, acute symptoms that require immediate medical attention. Rupture. If a cyst bursts, it can cause sudden, sharp, and severe pain on one side of the abdomen. While the rupture of a simple functional cyst often releases only sterile fluid and the pain resolves with rest, the rupture of a dermoid cyst, or endometrioma, can spill irritating contents into the pelvic cavity, causing a more severe inflammatory reaction. It is always essential to get a proper diagnosis to rule out other emergencies like appendicitis. Ovarian torsion. This is a rare but serious complication where a large cyst acts as a weight, causing the ovary and fallopian tube to twist on their supportive ligaments, much like an apple twisting on its stem. This cuts off the blood supply to the ovary. Ovarian torsion causes excruciating, sudden, and often unrelenting pain, frequently accompanied by nausea and vomiting. This is a surgical emergency that requires immediate intervention to untwist and save the ovary from dying. Getting professional help. Diagnosis and evaluation. Ovarian cysts are often found incidentally during a routine pelvic exam. If you are experiencing symptoms, or if your doctor feels a growth on your ovary, further testing will be recommended to determine the nature of the cyst. You should see a gynecologist or a family doctor for evaluation. The primary diagnostic methods include 1. Pelvic exam. Your doctor can often feel a cyst on your ovary during a manual pelvic exam. 2. Pelvic ultrasound. This is the most important and effective tool for diagnosing ovarian cysts. It uses sound waves to create an image of your uterus and ovary. A transvaginal ultrasound, where a small, thin probe is placed into the vagina, provides the clearest and most detailed images because the probe is much closer to the ovaries than it would be on top of the abdomen. The ultrasound can determine the cyst size, shape, location, and composition, meaning whether it is a simple cyst filled only with fluid or a complex cyst containing solid material or internal walls. This distinction is crucial for management. Blood tests. Pregnancy test. A positive pregnancy test can suggest that your cyst is a normal corpus luteum. Hormone levels. Checking hormone levels can help identify issues related to conditions like PCOS. SA1225. This is a blood test that measures a protein called cancer antigen 1. It is sometimes recommended for postmenopausal women with a cyst or for those with a very complex and suspicious-looking cyst on ultrasound. However, it is crucial to understand that this is not a reliable cancer screening test in premenopausal women. Many benign conditions, including endometriosis, uterine fibroids, pelvic inflammatory disease, and even menstruation itself, can cause elevated Cyst. It is just one piece of information that is considered in the overall clinical picture. Watchful waiting. This is the most common approach. If you have a simple fluid-filled functional cyst and have few or no symptoms, your doctor will likely recommend monitoring it. This involves having a follow-up ultrasound in 1 to 3 months to confirm that the cyst has resolved on its own. The vast majority of functional cysts will disappear with this patient approach. Medication, hormonal contraceptives, such as birth control pills, can be prescribed not to treat an existing cyst, but to prevent new functional cysts from forming. By providing a steady state of hormones and preventing ovulation, the pills stop the formation of the follicular and corpus luteum cysts that are part of a normal cycle. Surgery. Surgery may be recommended if a cyst is very large, is causing significant pain, persists or grows over several months of observation, or has complex features that appear suspicious on an ultrasound. The goal of surgery is to remove the cyst, a procedure known as an ovarian cystectomy, while preserving as much healthy ovarian tissue as possible. Laparoscopy. This is a minimally invasive surgery where a surgeon makes a few small incisions in the abdomen and uses a tiny camera and specialized instruments to remove the cyst. Recovery is much faster than with open surgery. Laparotomy. This is a traditional open surgery with a larger abdominal incision. It may be necessary for very large cysts or if there is a strong concern for cancer. If cancer is found, an oophorectomy, or removal of the entire ovary, might be necessary. Rehabilitation and alleviating symptoms. This can include using over-the-counter pain relievers like ibuprofen, applying a heating pad or hot water bottle to your lower abdomen, or taking warm baths with Epsom salts to help relax pelvic muscles and ease discomfort. If you undergo surgery, rehabilitation involves a period of recovery. For a laparoscopy, recovery is typically 1 to 2 weeks. For a laparotomy, it can be 6 weeks or more. During this time you will need to rest and avoid heavy lifting and strenuous activity as instructed by your surgeon. After a laparoscopy, you may experience shoulder pain for a day or two, which is caused by the gas used to inflate the abdomen during the procedure. Walking can help dissipate this gas. A significant part of rehabilitation is also psychological. The uncertainty of watchful waiting can be a source of anxiety. It is important to have open communication with your doctor, ask questions, and understand your follow-up plan. For many women, learning that their body is simply going through its normal hormonal cycles can be very reassuring and can reduce a great deal of stress. While there is no guaranteed way to prevent most ovarian cysts, if you frequently develop painful functional cysts, using hormonal contraceptives that suppress ovulation can be an effective preventative strategy. There is no way to prevent pathological cysts, like dermoids. Medical experts consistently emphasize that ovarian cysts are a normal part of being a woman. The focus is on accurate diagnosis to differentiate the common, harmless cysts from the rare problematic ones. Dr. Jen Gunter, a gynecologist and prominent women's health advocate, often works to demystify this topic. She frequently clarifies in her work that functional ovarian cysts are not a disease, but rather evidence of ovulation. This reframing is powerful, changing the perspective from one of pathology to one of normal physiology and reducing patient fear. The American College of Obstetricians and Gynecologists, or ACOG, provides clear patient information that underscores this point. Their guidelines emphasize that most ovarian cysts do not require surgery and that ultrasound is the best tool for evaluation. ACOG notes, functional cysts are the most common type of ovarian cyst. They are benign, not cancerous, and often shrink on their own without treatment. This official guidance from a leading medical body provides powerful reassurance. Research in this field is ongoing, particularly in improving imaging techniques and using biomarkers to better distinguish between benign and malignant cysts without the need for invasive surgery. There is also extensive research into the underlying causes of conditions like PCOS and endometriosis. The collective expert message is one of calm surveillance. Your body is dynamic, and the formation of functional cysts is a part of its rhythm. With proper medical evaluation and a good understanding of the process, you can manage this common condition with confidence.